The sacroiliac joint functions to transmit and absorb energy during weight bearing, both from the body and gravity. The anatomy consists of three bones. Directly affecting this joint is the ilium and the sacrum, and indirectly is the pubis symphysis. Ligaments are primarily anteriorly and posteriorly situated. Within the dynamic restraint system, muscles affect the pelvis and sacroiliac joint function. This includes a myriad of muscles: your abdominals, erector spinae, quadratus lumborum, lower traps, latissimus dorsi, your TFL, gluteus medius and minimus, your hip extensors, specifically the gluteus maximus and hamstrings, your hip flexors, the rectus femoris, sartorius, and iliopsoas, hip adductors, and the femoral external rotators, the piriformis in particular. Biomechanically, we have two motions that we have to understand about the pelvic area. We have nutation and counternutation. Nutation is the anterior-inferior movement of the sacrum. The paired ilia approximate and the ischial tuberosity separate. This is important for stabilizing the SI joint, especially important during standing and during the landing phase of gait, because we have increased forces on the SI joint. Counternutation is the posterior superior movement of the sacrum. In this movement, the paired ilia separate and the ischial tuberosities approximate, and this occurs during supine. When we think about the normal stance, the center of gravity falls posterior to the center of the acetabulum, and most weight of the trunk is transmitted through the posterior pelvis. This creates a posterior rotational force. The pelvis rotates posteriorly and downward around the acetabulum, creating an automatic pelvic tilt. When we lose this, we end up having some issues. So the mechanism of injury for sacroiliac joint dysfunction. Acute mechanisms include things such as during forward trunk flexion. If support is not available from the abs, additional weight causes the sacrum to settle vertically downward and lock the SI joint. So this means that the anterior movement relaxes the posterior sacroiliac joint ligaments and stresses the thinner anterior ligaments. You may have a misstep downward that is hard and sudden, and that sudden deceleration combined with an inertial moment on the sacrum forces the sacrum vertically downward. Additional mechanisms fall on the buttock. During golf, you may see it at the end swing during a drive, and then if you have falls that involve trunk rotation like during skiing. There's also chronic problems that can cause this dysfunction. A true leg length discrepancy can contribute. Muscular imbalances, such as your core being imbalanced. If you have a decreased flexibility and or strength of the core, or poor posture or ergonomics, especially with long periods of sitting, this causes an imbalance and can cause problems with that nutation, counternutation. Another contribution is pregnancy. During pregnancy, there's a release of relaxin as well as an increased weight on the anterior pelvis, and this is going to lead to sacral nutation. Signs and symptoms include localized SI joint edema. However, it is too deep to visualize because it's about 8 to 10 centimeters deep. There will be a pelvic obliquity, and one of the easiest ways to determine this is to assess the levels of the iliac crest and the ASIS-PSIS. The pain tends to be either unilateral or bilateral, never midline. It's almost always caudal to the PSIS, so your upper inner buttock will notice the pain. In acute conditions, it can be debilitating and localized pain to the SI joint, which is kind of at the level of your PSIS. During acute bouts, the person may be dysfunctional and have difficulty ambulating. In more chronic situations, they will find that there's pain with sit to stand and vice versa, and also pain with prolonged sitting. Range of motion will be decreased at the trunk and hip during active and passive range of motion. There are many different special tests that can be performed for this condition. I'm not going to share all of them with you, but give you several that you can have to start working with. The first is the long sit test. In the long sit test, the examiner stands with the thumbs on the subject's medial malleoli and compares to where the thumbs line up. You then passively flex both knees and hips and fully extends and compares the position of the medial malleoli relative to each other. The subject then slowly assumes the long sitting position and malleolar position is reassessed. A leg that appears longer in the supine position but shorter in the long sitting position is indicative of an ipsilateral anteriorly rotated ilium. Conversely, a leg that appears shorter in the supine position but longer in the long sitting position is indicative of an ipsilateral posteriorly rotated ilium. Gainsland's test is one of my favorite tests just to determine if the individual has some type of SI joint problem. The person on the edge of the table is simply going to have their upper leg lowered off the edge of the table, and pain in the SI region is considered a positive finding and may be associated with SI joint dysfunction. Yeoman's test consists of the examiner passively flexing the subject's knee to 90 degrees while simultaneously extending the ipsilateral hip. Reporting of pain during this test is considered to be a positive sign. Pain in the SI joint may be related to anterior SI ligament pathology. Pain in the anterior thigh region may be related to hip flexor musculature tightness or femoral nerve tension. The squish test is simply having the subject lie supine on the table, and the examiner places the hand on each of the iliac crests and the anterior superior iliac spines and compresses downward and inward at a 45-degree angle. The subjective complaints of pain are notated as positive findings and can be found both anteriorly or posteriorly. Any of the SI joint stress tests can also be performed. The examiner applying outward and downward pressure with the heel of the hands, the positioning of applying pressure inward and downward, or having the subject on their side and placing both hands on the iliac crest and applying a downward pressure, all can recreate signs and symptoms of sacroiliac pain. In the Gillette test, the subject is standing and the examiner places their thumbs on the PSIS bilaterally. The subject flexes one hip and brings the knee to the chest while the examiner maintains palpation to the PSIS and assesses overall SI movement. A positive sign is noted if the PSIS on the ipsilateral side of the knee being flexed does not move or moves minimally in the inferior direction. The PSIS on the side of the hip being flexed should move slightly anteriorly during the hip flexion. The last test is the sacroiliac joint fixation test. The examiner is first going to note whether the PSIS are level. If they are not level, the SI joints are asymmetrical, indicating fixation on one side or the other. The examiner then places one thumb over the PSIS on the right or left side and the other thumb over the S2 spinous process. The subject is then instructed to actively flex each hip one at a time with the knee bent at 90 degrees. This needs to be compared to the other side as well. When the subject flexes each hip, the thumb over the posterior superior iliac spine should drop relative to the spinous process. If there is no change or the thumb moves superiorly, hypomobility is indicated. In the last position test, the examiner leaves one thumb on the sacral spinous process and moves the other thumb to the ischial tuberosity. The subject is instructed to again actively flex one hip at a time with the knee bent to 90 degrees, comparing either side. When the subject flexes each hip, the thumb over the ischial tuberosity should move inferiorly. If the thumb moves superiorly, hypomobility is indicated. For manual muscle tests, we have to assess for weakness and contraction, and muscles are going to be tested based on the movements at the pelvis. So muscles that result in anterior rotation of the pelvis and SI joint include the rectus, the sartorius, hip adductors, and the iliopsoas. Muscles that result in posterior rotation of the pelvis are the hamstrings, and muscles that affect the sacrum are the gluteus maximus and the piriformis. For neurovascular concerns, we need to perform a lower quarter screen. Diagnosis is going to be clinical. Treatment includes correcting underlying cause of the discomfort, pain intervention, and potentially other techniques such as muscle energy techniques.